Yeah, live.
Good evening, everyone. Welcome to iFocus Online Lecture 297. And this is the fourth in the Ocular Oncology series. And we have with us none other than Dr. Santosh G Honavar, sir, who will be talking to us on retinoblastoma, the live and see. And before we hand over the session to you, sir, we would just like to mention that thanks a lot for taking care of these kids, and you have not just changed the entire the way retinoblastoma is seen in India. You have made it possible for several kids to get treated as per international standards. Thank you so much, sir. Over to you.
Thank you all for taking care of retinoblastoma, not just me alone. I just do maybe 1/10 of the work. Thank you so much. So I'll be talking about retinoblastoma 2023 as it is today, the live and see. Why should we know about retinoblastoma? Because it is the most common intraocular malignant tumor in children. It's a deadly tumor with potential for up to 50% of children dying if they're not appropriately treated. And it usually presents to an ophthalmologist or a pediatrician first, and we are responsible for its diagnosis and further management. It may present with squint, it may present with visual inattention, and it may go undetected if you're not aware of the symptoms and signs of retinoblastoma. And more importantly, it's completely curable if it is detected early and treated appropriately. If you really want to know how much is the incidence of retinoblastoma or what is the impact of retinoblastoma on each country, you should look at the world retinoblastoma map. You can see India in darker blue, which means that India has a very high incidence of retinoblastoma as compared to some of the other parts of the world. That's mainly because we have a high live birth rate. So once we have a high live birth rate, it is expected that the incidence of retinoblastoma is also going to be high because it is 1 in 10,000 to 15,000 live birth. That's just an estimate. So we have a high retinoblastoma load in India. And in the world, we have about 5,000 to 6,000 new cases every year. We have about a third of these, or maybe 40% of these happening in India. There is no real data, unfortunately, so far. When we surveyed all the major retinoblastoma referral centers in 2017, only 600 of these came to these referral centers. In 2022-2023, there was not much difference. Maybe 800 of these come to referral centers, which means that about 50 to 60% or even 70% of these children are treated in primary or secondary settings, where only enucleation is possible. Any stage of retinoblastoma, enucleation is possible. And that has about 30 to 50% mortality. So if you only treat any child at any stage with enucleation without any prior treatment or adjuvant treatment, then the mortality is very high. So what it means is that only about 30 to 40% of children in India are getting appropriately treated, and rest of them have just an enucleation done without any other form of treatment with high mortality. This is the statistics in rest of the world or in developed countries, where we began with 98% mortality. That was about 123 years ago, 98% mortality. In 2023, we have more than 98% survival. That kind of a turnaround hasn't happened for any malignancy except retinoblastoma. None of the other malignancies have such a dramatic improvement in prognosis except RB, and that's something that we must remember. So what it means is that awareness is the key to early diagnosis. And next month, we will be observing the World Retinoblastoma Awareness Week, where this will be actually stressed upon that early diagnosis is important and awareness is the key. Awareness at every level: parental awareness, awareness among medical care professionals, and awareness among pediatricians and ophthalmologists. Now, what are the clinical manifestations of retinoblastoma? About 50% of children present with leukocoria. So the most common presenting symptom is leukocoria. And you should remember that when leukocoria is already there, about half of the eye is already involved. That means the eye is filling about 50% of the globe. It may be an early sign in a child with macular retinoblastoma for an observant parent or a grandparent. Generally, it's the grandparent who has the child on the lap during daytime. And when the light reflects the tumor, that is when they observe a glint of leukocoria, and that goes away as the child moves the eye or the head is moved, it simply goes away. So they may observe a momentary glint in the eye, and that can be picked up as leukocoria. But currently, every parent is fond of taking a lot of pictures of their children, and it will be picked up in one of the pictures because pupil in the eye with affected retinoblastoma may be larger because of RAPD, and it will definitely be picked up if a photograph is very carefully seen. So you may actually see leukocoria in pictures. In any case, 50% of these children present with leukocoria as the primary symptom. It is also the most important primary sign. So whenever there is leukocoria observed by the parents, it's also observed by the medical care professionals. So it is the most common sign as well. About 25% of children present with squint as the primary presentation. And the squint can be esotropia or exotropia depending on the location of the tumor and age of onset. Esotropia is more common, as you see in this child, than exotropia. And even when the child has squint, you can see a glint of difference in reflex. You can see that this pupil is absolutely jet black, whereas this pupil is slightly pinkish. So that kind of a glint you will observe. So what it means is that any child who has squint has to have a dilated fundus evaluation, either with constraint, you can hold the child back and look at the fundus, or momentarily distract the child and look at the fundus, or look at the fundus in a sleeping child. You will not miss retinoblastoma because whenever there is squint, there's a posterior polar tumor. And that will be easily visible when you do a indirect ophthalmoscopy, even in an awake child. You don't have to anesthetize the child to look at the fundus. That kind of misconception should be avoided. Whenever there is squint, there is a posterior polar tumor, and that can easily be picked up on even a cursory indirect ophthalmoscopy, but indirect ophthalmoscopy for sure. Now, reduced vision is because of many reasons. Most important would be the location of the tumor. Macular foveal tumors obviously will have reduced central vision and visual inattention. If the tumor is in the periphery, then it takes time for the vision to go away, because then the cause for loss of vision would be subretinal fluid or a large tumor. So either which case, vision will be lost at some stage in the manifestation of retinoblastoma, more commonly in macular and posterior polar tumors, and less commonly in peripheral tumors. So younger children will have more of loss of vision than older children, because younger children will have a posterior polar tumor, whereas older children will have a peripheral tumor. So older children present to you much later, only because their loss of vision as a manifestation happens much later. They have a peripheral tumor. Younger children may present with visual inattention very early because they have a posterior polar tumor, which is visually crucial in location. So manifestations differ depending on the age. Now, redness is an uncommon symptom or a sign. Redness happens only when the eye is inflamed or the tumor is so large that there is vascularization that is evident. Episcleral vasculature that is evident in this patient is mainly because the child has ciliary body invasion. Of course, there is cataract as well. So red eye is rare, and that's a sign of inflammation, and that's also a sign that the child already has an advanced tumor. Fortunately, this is becoming rare in India. About 20 years ago, this was possibly one of the more common manifestations of retinoblastoma, especially in remote parts of our country. Now, hardly any child comes with orbital RP, less than 5%, which is very gratifying from 50% that we used to see 20, 30 years ago. This is the clinical spectrum of manifestation of retinoblastoma. Starts off as a small tumor in the posterior pole, at which time you will see visual inattention or strabismus or leukocoria. When it fills about 50-60% of the eye, you will obviously see leukocoria. Strabismus is a manifestation. Whenever there's a flat eyelid, means there is no eyelid edema, yet proptosis, that means that there is extraocular extension. Whenever there is eyelid edema and proptosis, it does not always mean extraocular extension. It could just be sterile orbital cellulitis with a necrotic tumor. So you should look at the flat eyelid. Without inflammation, definitely extraocular extension. With inflammation, maybe an extraocular extension, and that's a fungating mass. Now, we should also know that a child who has retinoblastoma very early in life has a tumor in the posterior pole. So if I find space to draw the tumors, okay, I don't have space there. Okay, let's go and draw here. Right. So if this is a fundus, now if a child is born with retinoblastoma, you'll find bang in the fovea foveolar area. If a child has retinoblastoma at about 3 to 6 months of age, then you will find the tumor right adjacent to the arcades, superior or inferior arcade. 6 months to 9 months, they will have it anterior to the arcade. 9 months to a year, they will have somewhere close to the equator. Year later, they'll be more anterior to the equator. And then at about 2-3 years, it's most likely to be a peripheral tumor. So depending on the age of onset of retinoblastoma, the location of the tumor itself varies. So in an older child, your examination is incomplete unless you look at the periphery. Whereas if you are screening a newborn, don't give the excuse that the child is not fit for anesthesia, so we could not screen. No, that is not the situation. You can actually screen just the posterior pole and up to the equator and very fairly, reliably say that the child doesn't have retinoblastoma, because it's very, very unlikely that a newborn manifests with a peripheral retinal tumor. That's important. Looking at the mask rats, eyelid edema simulating orbital cellulitis can be a manifestation of retinoblastoma. This happens in children with sterile orbital cellulitis because of a necrotic tumor. Retinoblastoma is a round cell tumor, and round cell tumors rapidly grow. Sometimes they overgrow their blood supply. Part of the tumor becomes necrotic, and any necrosis in the eye induces inflammation. And this is a spillover orbital inflammation in a patient with sterile orbital cellulitis. So what does this slide mean to us? Means that if a child comes to you with orbital cellulitis or even severe eyelid edema, your examination is never complete unless you look at the fundus. Suppose you're not able to look at the fundus, at least an ultrasound B scan, if not imaging. That is mandatory in every child with orbital cellulitis because we don't know what is lying behind. Next is uveitis. Any child with uveitis. Uveitis is extremely rare in extremes of age group. Child with uveitis has to be considered as having retinoblastoma or medulloepitheloma unless proved otherwise, especially in a child where there is white eye hypopyon. This is a classic manifestation of retinoblastoma in older children. And why does that happen? That happens because the tumor is more anterior. It involves the ciliary body very early, and the tumor cells come through the zonules and get deposited in the anterior chamber. When you do ultrasound on these children, you will not find, you're most likely not find a calcified tumor, because in older children, retinoblastoma tends to be diffuse infiltrative and acalcific. When you look at their fundus, you may not find any tumor at the posterior pole or up to equator because the tumor tends to be peripheral. So in a uvea clinic situation, unless you do examination, the anesthesia with indented 360-degree evaluation of the periphery of the retina and maybe a ubium, you're going to miss retinoblastoma lying in the periphery. And these children are often misdiagnosed as other simulating conditions, and they are inappropriately managed, sometimes even with Ozurdex implants and stuff like that, or vitrectomy. In fact, endophthalmitis in children has to be taken with lot of care, because it's one of the manifestations of retinoblastoma, and vitreoretinal surgeons jump to doing a vitreous biopsy in a patient who is likely to have endophthalmitis. In a child, endogenous endophthalmitis is a possibility, but you should definitely rule out retinoblastoma before venturing to do a vitreous biopsy or an intravitreal injection, which will make the tumor extraocular. Now about congenital glaucoma. Retinoblastoma can also simulate congenital glaucoma because of the high intraocular pressure. Cornea is something that would enlarge and it will look ophthalmic. Now this child has bilateral retinoblastoma and you can't miss the pinkish sheen, but that may not always be so. In children who have much hazier cornea, suppose this child had unilateral retinoblastoma and a much hazier cornea and such a large corneal diameter, say 16 millimeter corneal diameter, what would the glaucoma surgeons think of? He would think of a developmental glaucoma or a congenital glaucoma. And if they don't do ultrasound and then venture on to do a trap plus trap, you can understand the consequences. So no child with glaucoma should be subjected to surgery unless we have seen the fundus, and fundus evaluation is not possible. Then you must do a ultrasound B scan with immersion before you venture on to do glaucoma surgery. Next is a phthysical eye. Now often parents give a history of small trauma to the eye and we think that, well, that has caused this phthisis. Well, that's always possible. Trauma may have predisposed an eye with a tumor to bleed or necrose, and that may have precipitated phthisis. So any eye in a child with phthisis or atrophic bulbi should be taken very seriously, and you're supposed to look at the B scan and also a CT scan. How does it differ? Calcium in an eye with phthisis and calcium in an eye with retinoblastoma. In a calcium in an eye with phthisis, you will have peripheral calcification or sclerochoroidal calcification. A rim of calcification like this will go with dystrophic calcification in a phthysical eye. Whereas if it is intraocular calcification, that means that the child has retinoblastoma unless proved otherwise. So phthysical eyes and atrophic eyes should be taken very seriously. Next is hyphema. Now, any child with retinoblastoma can bleed with minor trauma. This child has a history of trauma and a lid laceration to even support the fact that the child indeed had trauma. We agree with that. Child has hyphema, and somebody did a hyphema drainage in this child without paying much attention to B scan, and look at the consequence. The child has extraocular extension, regional lymph node metastasis, and an intracranial extension 6 months later. This is unsalvageable. So we have to definitely do imaging. Again, I'm stressing the role of imaging in a child with any manifestation, including hyphema or even vitreous hemorrhage. This child presented with vitreous hemorrhage, but you can note that the blood vessels are dilated. In a child with traumatic vitreous hemorrhage, as this was assumed to be, blood vessels have no business to dilate. And you can also see that there is something creamy white in the middle of blood. That could, of course, be blood in various stage of evolution. And obviously, vitreous hemorrhage can condense, can resolve, partially get absorbed, but that looks slightly suspicious. Somebody did a vitrectomy and then they had a complication, rhegmatogenous RD, they did a scleral buckle, and on top of the scleral buckle, now you find creamy white lesions, which is about 6 months later. Now, posterior to the buckle, you find something which is absolutely creamy white, which was never there earlier. So now we have a situation here where a peripheral lesion is creeping posteriorly, and what else could that be except a retinoblastoma in an older child? This is the stage when we enucleated this child. There was nothing on B scan to suggest intraocular calcification, and this histopathology sums it up. This is normal. This is thickened retina, which is twice as thick as normal retina, which you can see on the side, and there is no calcium at all. This is not the kind of tumors that you're used to seeing, isn't it? You are used to seeing a tumor which is like elevated like that. But in diffuse infiltrative retinoblastoma, tumors just hug the wall of the eye along the retina, and all you see is thickening of the retina. And you should pay a lot of attention to diagnose this as diffuse infiltrative retinoblastoma. These are the children who are misdiagnosed and inappropriately managed. You can see that this is normal retina, that is thickened retina. It's just twice as thick as normal retina. Yet this child has iris involvement, anterior chamber angle involvement, ciliary body invasion, everything. All the risk factors are there in this child. You should always remember that masquerades of retinoblastoma are more common in older children. It's the older children who manifest with retinoblastoma with unusual features, and you should remember that as well. Now, when we talk about intraocular retinoblastoma, we have four typical clinical configurations. One is endophytic, which is most common. About 60% of children manifest with endophytic retinoblastoma. About 20 to 30% may manifest with exophytic retinoblastoma. Endophytic grows into the vitreous cavity with vitreous seeds, whereas exophytic causes exudative retinal detachment and classically manifests with subretinal seeds. Diffuse infiltrative is this. This is rare manifestation of retinoblastoma, about 2 to 5%. And what is also common is mixed configuration, where there is a bit of that and bit of this. There is some endophytic component, some exophytic component, some diffuse infiltrative component. But whenever we classify retinoblastoma, we take the most prominent configuration as the configuration. If 90% of the tumor is endophytic, you would want to call it endophytic because it has a different connotation. If 60-70% of the tumor is exophytic, you call it predominantly exophytic retinoblastoma. You reserve the term mixed configuration to almost an equal manifestation of endophytic and exophytic. So that's why we say that endophytic is more common than anything else. About 70% in India present with advanced retinoblastoma. That's all I wanted to show this slide for. Now, how do you diagnose retinoblastoma? The most important diagnostic tool is indirect ophthalmoscopy, appropriately performed indirect ophthalmoscopy. The testing conditions are the child should be under anesthesia, and you have to have a fully dilated pupil. You have to use your cotton tip applicator or any other indenting device that you use and indent the ora serrata 360-degree and screen twice over. Unless you have done a good indented indirect ophthalmoscopy under anesthesia with a fully dilated pupil, you cannot be sure that the child doesn't have retinoblastoma. Ultrasonography B scan helps you diagnose if there is any intraocular calcium, and you can also measure the height of the tumor. That is the advantage. So if you have a situation where you're not able to look at the tumor very carefully because there might be a total retinal detachment making the tumor invisible or not clearly visible, or there may be cataract, there may be corneal scar, etc., then you should readily do an ultrasound B scan so that you detect intraocular tumor and calcification. CT scan is generally not done unless you have a confounding situation where you must look for calcification. Otherwise, whenever you want imaging, then what we prefer is MRI, because MRI does not give radiation, whereas CT, although less, can give some amount of radiation, and that may induce a second malignant neoplasm in a predisposed child. Now, what are the lesions simulating retinoblastoma? These are the 5 most common conditions: Coats disease, PHPV, toxocariasis, astrocytic hematoma, and medulloepithelioma. In Coats disease, you have, of course, a whitish reflex, but that's not pearly white or creamy white or yellowish white. That is tinged with golden yellow kind of a color. So this is called xanthochoria. Xantho is yellow, whereas leuco is white. You can see, although this is maybe called white reflex by a stretch of imagination, this is white reflex. This is xanthochoria. So whenever you have this yellowish white reflex, you call it xanthochoria, and that is classic of Coats disease. When you go closer to the patient, you'll see this. You'll already see, without even looking at the periphery, you'll already see that there is intra and subretinal exudation here. There are some dilated vessels, and there is some telangiectasia, which of course will be more prominent peripherally, but even in the posterior pole, equatorial area, you'll be able to see some telangiectasia. So whenever you have xanthochoria and intra and subretinal exudation and telangiectasia, your diagnosis is in favor of Coats disease, especially when you see this kind of segmental dilatation of blood vessels and terminal telangiectasia. That confirms clinically that you're looking at Coats disease. Retinoblastoma blood vessels are large, of course, but they dip into the tumor, never to emerge. So that's a feeding vessel in retinoblastoma, whereas Coats disease does not have any such. When you look at the B scan, it is more characteristic. You find in Coats disease detached retina, exudative retinal detachment, and thickening of the retina. You can see how thick this retina is because it's all exudation, intraretinal, whereas in retinoblastoma, you find a tumor. Now, if you still have any doubt, you can do FFA that shows peripheral retinal telangiectasia very vividly, whereas in retinoblastoma, you don't have much of that. Now, if a child has PHPV, then you'll find relative microphthalmus. Relative microphthalmus is just that the corneal diameter may be 0.5 millimeter or 1 millimeter less than the normal contralateral eye. Even 9.5 millimeter, 10 millimeter is considered relative microphthalmus for the purpose of diagnosing PHPV. It's always present at birth, and you'll find, if you look at carefully, prominent ciliary processes which are drawn towards the lens. And of course, if this is the lens, there will be a vascular pedicle that goes and gets attached to the optic disc. That's prominent hyaloid vessel. So with you, when you have all these attendant features, then your diagnosis of PHPV becomes very rare. When you do ultrasound B scan, you'll find there's a fibrovascular front starting from the posterior pole getting attached to the optic disc. That's PHPV, whereas in retinoblastoma, you don't find that. In toxocariasis, there could be some spillover uveitis. So if you have a child with white reflex with some cataract and posterior synechia, then you may consider toxocariasis. Whereas in retinoblastoma, finding posterior synechia is very rare unless the child has been treated and there is some uveitis, etc. Now, peripherally located toxocariasis can have intralesional calcium, and that may actually simulate retinoblastoma, but you should pay careful attention to other attendant features such as a fold of retina. So this kind of a fold and a traction band indicates that the child has toxocariasis, whereas RB generally does not have traction. In a posterior polar toxocariasis, there is what is called a dragged disc appearance. Toxocariasis causes a lot of desmoplasia, because of which the blood vessels appear dragged towards the lesion, and you can also see a dragged disc appearance there, right? So whereas in retinoblastoma, you don't find any such features. The next one is retinal astrocytic hamartoma, which is of two types. One is non-calcified and the other one is calcified. Non-calcified one is like a button sitting on the retina obscuring the blood vessels, whereas calcified one has this fish egg kind of calcification, which are very characteristic, unlike retinoblastoma, which has dense calcification. If you have a retinoblastoma, you'll find this kind of a dense calcification rather than fish egg kind of calcification. The last one is medulloepithelioma. It's an embryonal tumor. It's a peripherally located ciliary body tumor. So since it is present during the stage of evolution of the child, zonules are missing in that area. So you'll find a lenticular coloboma, zonular coloboma, and a ciliary body mass in medulloepithelioma, whereas in retinoblastoma, you don't find that. So because of the hyaline cartilage within the pterygoid medullary epithelioma, you may find signs of calcification, ossification, etc. But that doesn't mean the child has retinoblastoma. You have to pay very careful attention to the location of the tumor. Medullary epithelioma is a ciliary body tumor. It may be slightly larger, may overhang the retina, but primarily it's a ciliary body tumor, and it can easily be picked up on a ultrasound biomicroscopy done under anesthesia or on imaging. Now, going on to classification of retinoblastoma, any successful tumor classification should ideally follow a logical sequence of evolution of the tumor. That means that if a tumor evolves in a particular way, your classification should actually mirror it, because ultimately, what is a classification for? It is only to prognosticate the child. It's only to tell the parents and tell yourself, okay, this child has group D retinoblastoma. This is how I'm going to treat it. And this is the ultimate prognosis. So you tell the parents and tell yourself that, okay, this child has a group D tumor and this is how it's going to be. So that's the purpose of classification. And so it has to follow a logical sequence. Second is that it's not something that would be very complicated. You should not be referring to a chart on the wall to classify the tumor. It should be right off the cuff. You look at the tumor, you say it is group C or group D without having to look at something which is written on the wall. So it has to be very simple and easy to recall and practical. And most importantly, it should be applicable to current therapies. There is no point using a classification system where radiation was the treatment. Currently, chemotherapy is the treatment. So your prognostication should be applicable to what is current. So whenever we have any cancer classified, we have staging and grouping. Both are important. In staging, survival is the outcome measure, survival of the patient. So life salvage is the outcome measure in staging. Organ salvage is the outcome measure in grouping. So staging is totally different from grouping. Every child has to have staging and grouping. This is the international staging of intraocular retinoblastoma. Stage 0 is when no enucleation has been performed. Both the eyes or one or both the eyes have been salvaged by non-enucleation techniques. So that means that the child has the best prognosis. No enucleation has been performed. In stage 1, enucleation has been performed and the tumor is completely resected. This complete resection has to be informed to you by the pathologist. So pathology has a very big role in staging. Pathologist has to tell you that the tumor has been completely resected. If the pathologist gives a report that there is full thickness scleral invasion or optic nerve extension, it immediately becomes stage 2, where tumor has been resected by enucleation with microscopic residual tumor. Microscopic means that it may not be picked up on imaging, but nevertheless, histopathology is able to pick up that the cut end of the tumor cut end of the optic nerve has some tumor residual. Stage 3 is regional extension into the orbit or regional lymph nodes. So up to this point, up to stage 3, there is excellent prognosis. Stage 0 has 99 to 100% life salvage. Stage 1 also has 98 to 99% life salvage. Enucleation microscopic residual also has about 95% life salvage. Orbital extension also has 90% life salvage. But beyond this, it very drastically falls. Whenever there is hematogenous metastasis, life salvage is very less, 5 to 10%. CNS extension, less than 2%, less than 1% even of life salvage. So this is the watershed zone. We have to catch retinoblastoma before it has systemically metastasized. If it's in the orbit or regional lymph node, it is still okay. But once it metastasizes hematogenously or into CNS, then the prognosis becomes extremely bad. Grouping used to have Rees Ellsworth and SN as earlier classification systems, but what is currently used is International Grouping of Intraocular Retinoblastoma. It's a simple, straightforward classification where Group A is a tumor which is less than 3 millimeter. It's a kindergarten classification, very simple to remember, A, B, C, D, E. B is for a bigger tumor, macular location, or less than 3 millimeter from the fovea, or less than 1.5 millimeter from the optic nerve. So B is for a bigger tumor, right? B also means that there is subretinal fluid. So B is for a bigger tumor with subretinal fluid. C is for a tumor with contained or confined subretinal seeds. Now, subretinal seeds occur in exophytic retinoblastoma. So, a tumor with subretinal seeds around it will be group C. Endophytic retinoblastoma will have vitreous seeds. So, tumors with vitreous seeds on top of it or around it will be group C. Group D is for seeds which are diffuse. Diffuse means more than 3 millimeter away from the tumor. So group D is mainly for diffuse subretinal seeds or diffuse vitreous seeds which are more than 3 millimeter away from the tumor. Less than 3 millimeter is considered focal. Now group E are potentially enucleable eyes with more than 50% of the eye filled with a tumor, neovascular glaucoma, hyphema, vitreous hemorrhage, or evident invasion on clinical evaluation, say anterior segment invasion, etc., fall into group E. This is international grouping of intraocular retinoblastoma. What is new in retinoblastoma grouping is TNM classification. TNM classification is grouping plus staging. It's a combined classification. So you can't call it just grouping. But what is new is, I don't expect anybody to remember this. This is a complicated classification, but it is better than anything else because it has taken a lot of evidence into consideration about life salvage. And if you're able to use it, then that's only for the purpose of research. It's not used on a day-to-day basis. But what is important about this is that it has used for the first time the letter H. TNM is tumor node metastasis. Now for retinoblastoma, we have H as well. H is for heritable trait. That brings to forefront the role of genetics in the screening of retinoblastoma and also prognostication, which is an important development. Now we are supposed to do genetics if you have to follow TNMH classification, and it is helpful for families as well. So that's better that we do it. Now going on to management. Retinoblastoma has been a success story in the West. I told you already that survival has improved to more than 98%, mainly because of early diagnosis and improved methods of treatment. Any child with larger tumor, much advanced disease has much worse prognosis. So goals of management of retinoblastoma, number one is to salvage life. Eye salvage or organ salvage comes as a secondary goal. Function salvage is only a tertiary goal. You should never attempt your treatment, or your aim should never be to save vision at the cost of life or save the eye at the cost of life. That is the basis of management of retinoblastoma. You should try to save life. Then if that is possible, save the organ, and if that is possible, optimize residual vision. So your management protocol is based on exactly these principles, and the treatment modalities that are available are quite a few. When you have a small tumor, say a tumor of 3 to 4 millimeter in diameter, 3 to 4 millimeter in thickness, that's a small tumor. And we know that a group A, B, C tumors have 100% life salvage. So there is nothing to worry about life. There is nothing to worry about eye salvage. Eyes are also 100% salvageable. Then you worry about vision. So when you have a small tumor, you don't go with the idea that we have to eradicate the tumor at the cost of vision and eye salvage. Obviously not. You have to maximize vision in a small tumor, and that is the principle. So if you have a tumor in the periphery, you can cryo it with good success. Cryo has more than 90% success. But the problem with cryotherapy is that since it is triple freeze thaw cryotherapy, it's a heavy form of cryotherapy. Because of spillover, you will get a much larger scar. That's okay as long as the tumor is in the nasal periphery, but once the tumor is on the temporal side or somewhere even anterior to the equator, temporal side. If you do heavy cryotherapy, there may be some traction on the macula fovea. There may be some epiretinal membrane formation. If you do recurrent cryotherapy, then you will induce atrophic retinal bricks causing rhegmatogenous retinal detachment. You will induce some tractional element. So it's not a very good idea to do cryo to every patient with retinoblastoma unless that's the only treatment modality that you have, or the child has SRF. If a child has subretinal fluid on top of the tumor, or the tumor is very fragile endophytic, some tumors are really fragile endophytic and have some vitreous seeds on top of them, you can't laser them. They will break if you laser them. So then cryo is good. But as long as that doesn't happen, and if it's a compact tumor, then you have other options. This is how we do cryotherapy. It's called triple freeze thaw cryotherapy. That means you have to freeze the tumor thrice and let it thaw thrice spontaneously. How exactly do you do it? You use a large diameter cryoprobe. 3 millimeter is perfectly all right. You can also use a 2 millimeter cryoprobe and lift the tumor and center it on the tip of the cryoprobe. This pressure that you put on the peripheral sclera or retina indirectly anemizes the tumor. That means that it cuts off its blood supply temporarily so that the effect of cryo comes right on the tumor. If you simply touch the cryoprobe to the sclera and try to cryo it, most of the ice ball will lie extraocularly, sclera will get frozen very late, and you will have a lot of inflammation because you are freezing the orbit and not the tumor. So your tumor has to indent the sclera and it has to be centered on the tip of cryoprobe, and you have to make sure that this kind of a elevation is there on top of the cryoprobe. Then you press the foot switch and let the entire tumor freeze to chalky white, and on top of that the vitreous, cuff of vitreous that is lying anterior to it should also be included in the ice ball. So that's a heavy cryo, and let it spontaneously thaw. There is no hurry in thawing. Let no one squirt saline on the eye to thaw it. Let it thaw spontaneously and then freeze it again and thaw it again and do the same thrice over. So that's how you get this large scar. Now, photocoagulation is the second modality of focal treatment. I mention all these because these are still used in some of the centers, but we would not generally recommend these modalities of management. The principle of photocoagulation is not to laser on the tumor. If you laser on the tumor, you will rupture the internal limiting membrane and you will induce a vitreous seed. Whenever you do photocoagulation, the principle is that you do around the tumor. So use large diameter laser burns and do 2 rows of confluent laser burns around the tumor, like that. So when you do that, you can see how large the scar is going to become. Scar is going to become in area at least thrice as the size of the tumor. You can calculate the area of a circle, that is 2 pi r, right? So, or pi r squared, sorry. So when you do that, you'll find that the area of the circle will be much larger. The scar will be much larger than the tumor that you began with. I'll show you an illustration here. Tumor has been surrounded with 2 rows of large diameter laser burns. That is the size of the tumor. That's the size of the scar. Not to forget the blood vessel coagulation or that it has produced. So small vessels obviously get blocked. There is vascular occlusion. And if you have a tumor, say in the juxtapapillary area, and if you do laser photocoagulation, the child will have an inferior arcuate field defect. So visual field defect is imminent, vascular occlusion is imminent, large scar with focal scotoma is imminent. If you overlap laser spots on the tumor, there will be internal limiting membrane rupture and vitreous seed formation. And most importantly, if you do photocoagulation during the time when the child is on chemotherapy, it will cut off chemotherapy uptake by the tumor because you are cutting off the blood supply. The principle of photocoagulation is anemization of the tumor. You cut off its blood supply from all sides and let the tumor die. And that cannot happen when the child is on chemotherapy. So what we currently use, if somebody asks you what is the standard of care or gold standard for focal therapy, it's not cryo or photocoagulation, it is transpupillary thermotherapy. Indirect ophthalmoscopy delivered transpupillary thermotherapy has no anatomical barrier. You can reach right up to the ora serrata with indirect ophthalmoscope, and the spot size here is 1300 micron, which is very good because you can cover a large surface of the tumor in a very short time. Chemotherapy when you do and you give TTT as an adjuvant therapy within 3 to 6 hours before or after chemotherapy, then it is synergistic. It's called chemothermotherapy or thermochemotherapy when done before or after chemotherapy, and it has synergistic benefit, and that actually increases the uptake of carboplatin within the tumor, and that gives you much better regression of the tumor. So you can use thermotherapy to your advantage if the child is on chemotherapy. Thermotherapy does not cause photocoagulation. It only increases intratumoral temperature to about 45 to 60 degrees centigrade, thus inducing tumor cell apoptosis. So it's a very gentle form of therapy. Your endpoint is not photocoagulation. Gentle whitening of the tumor is your endpoint. And if you cannot do that to the entire extent of the tumor, simply don't worry, you always have the second session to do. So never over-treat a tumor with TTT. Treat only as appropriate, and you derive all these benefits. A crisp scar, which is not larger than the tumor that you began with, and blood vessels passing through the area, very nice and patent. So you don't have any secondary effects or complications more than what you should have or expect. So TTT is extremely good for retinoblastoma. That's a closer view of the scar. Now, if you can't use TTT for certain reasons, like this patient has a amelanotic or a non-pigmented scar already. That's the scar that we already had. Now, on top of that, there is an unfortunate recurrence. That's between the disc and the scar. Now, how are you going to treat it with TTT? TTT or any form of laser is dependent on the uptake, and the child must have a pigmented background, ideally, for the laser to have a good uptake. Now, if that is not happening, then you can use indocyanine green as a potentiator. So indocyanine green has synergistic effect. I can't call it photodynamic therapy. It does not really fit into the definition of photodynamic therapy so much, but it is actually a sensitizer to TTT. They work synergistically. And if you have an amelanotic scar or a tumor that is not responding to TTT, then you can use ICG enhanced TTT, which is much better in tumor regression. Now, we had a small series where we had about 20 tumors that were treated with ICG enhanced TTT. Is yet to be published, but this was a poster at the Academy where we showed that there is 80% regression of refractory tumors, which otherwise would not have responded to transpupillary thermotherapy. So for focal therapy, less is more in terms of vision. TTT has definitely taken over, and photodynamic TTT or ICG enhanced TTT are good for tumors which are in a non-pigmented background or have refractory tumors. For larger tumors, when the tumor is, say, group C or group D, you can't use focal therapy alone. And you also know that life is not at risk. Now your goal is to save the eye and maximize vision. So for a larger tumor, your goal suddenly changes to eye salvage and maximizing vision. It's not just vision salvage alone, and life is not at risk. So in such a situation, plaque brachytherapy used to be an option. Larger tumors up to 16 millimeter in diameter, 8 millimeter in thickness could be treated with plaque brachytherapy, but it is a modality that is not used primarily anymore unless the child has some problem in receiving chemotherapy, systemic issues or whatever. Right? So it is always used as a secondary measure, although it has impressive tumor control. I'll show you why that is done. Skip this slide. This is a child with plaque brachytherapy done extremely well, but you can see in a given situation that it is not always that you get gratifying response. This is the tumor where we had to do plaque brachytherapy because the child was not tolerating chemo well. Tumor has regressed. This is a very stable scar, but if you look at it very carefully, there is vascular occlusion and the scar is all over. Wherever the tumor was, there is all scarring. So plaque is not a good modality if you want to conserve vision, especially if the tumor is already large. You have to shrink down the tumor using chemotherapy, and whatever that is residual can be treated secondary with plaque brachytherapy or for recurrent tumors. So plaque has specific indications, although it is good. Now, EBRT is something that needs to be mentioned only to be condemned. It has reasonable success, not very impressive. It was used 40, 50, 60 years ago where there was no other option. But now we realize that it has a lot of complications, some of which is reversible, some of which is irreversible. But the most important or a dreaded complication is second malignant neoplasm. It increases second malignant neoplasm to 35%. About 35% of these patients die because of a second malignant neoplasm. And if you don't use radiation, the chance of SMN is 6%. So we are responsible for 30% of obviously succumbing to second malignant neoplasm if we give radiation in a child with heritable retinoblastoma less than 12 months of age. So we should avoid all forms of radiation in a heritable retinoblastoma situation. So we don't give radiation at all in a child with heritable retinoblastoma unless that is the only option that is available to save the eye or life. So EBRT is not favored at all. What changed the management of retinoblastoma is this issue of JAMA Ophthalmology, or then called Archives of Ophthalmology, November 1996 issue. If you can get hold of this issue, if you have interest in retinoblastoma, then you can see how it has evolved. Generally, editors don't publish 4 articles on the same topic in the same issue. But this was a situation where 4 different groups were working on the same idea. And all the idea had originated from a couple of pediatric oncologists who believed that this form of chemotherapy has a role much better than radiation. So all these groups published their data, and the editor gave them all a chance to publish the data. But it was Dr. Kingston, who was a pediatric oncologist, who was working with Hungerford, who spearheaded this technique, apart from, of course, Dr. Shields' group, who also did it simultaneously, and Lynn Murphy and Dr. Brenda Galley. So the 4 different groups from 3 different countries and 3 different continents, which spearheaded in intravenous chemotherapy. It was considered very, very dramatic, a paradigm shift in the management of retinoblastoma. It was called back to the past, because a tumor which was like 16 millimeter in diameter could be shrunken down to 4 millimeter in diameter, as if the child came to you 6 months ago before, he actually manifested to you. So you could actually take time back and then treat the tumor in a much reduced fashion after giving chemotherapy. It was extremely useful. It is still extremely useful. This is what we started off with: standard dose intravenous chemotherapy. That was the only form of chemotherapy available in 1996 when I began my practice. Now we have all these forms of chemotherapy. Chemotherapy given in all these forms is a boon in the management of retinoblastoma. So IVC, or intravenous chemotherapy, is a method of reducing tumor volume to allow for more focused, less damaging therapeutic measures. That's a definition. And that definition conforms to the definition of neoadjuvant chemotherapy. So intravenous chemotherapy or chemoreduction in retinoblastoma can be called with various terms, but in oncological terminology, it is neoadjuvant chemotherapy. That means that before performing any surgery, you are delivering chemotherapy. The drugs that are used are carboplatin, etoposide, and vincristine, 3 to 4 weekly, up to 6 cycles. And examination under anesthesia is mandatory before each cycle. If you do chemocryotherapy, which is nothing but a peripheral retinal cryotherapy, then you're actually increasing the intravitreal concentration of these medications because you're breaking the blood-retinal barrier. So it is done in the nasal periphery. And focal therapy as appropriate from 3rd or 4th cycle onwards. That is the complete protocol in the management of retinoblastoma when we use intravenous chemotherapy. How all does it work? Number 1, it shrinks the tumor down, as I already mentioned repeatedly. There are 2 tumors here. When they're shrunk down, you can see that the scar is much smaller than the tumor that you began with. So macular fovea gets exposed very early in the course of treatment, thus maximizing vision. Second principle is that the tumor always hangs on to its source of blood supply, which means that if a tumor is abutting the fovea in primary manifestation and it is receiving blood supply from the arcade, majority of tumors receive blood supply from the arcade. Supratemporal, infratemporal, supranasal, infranasal really doesn't matter, but a posterior polar tumor, which is the one which has visual connotation, receives blood supply from the arcade. And in such situation, tumor always regresses towards its source of blood supply. It leaves macular fovea very early and regresses towards its source of blood supply, as evidenced here. Tumor abutting the fovea. 1 cycle later, tumor has left the fovea and has moved towards supratemporal arcade. 6 cycles later, tumor is all flat and the macula is all healthy. This is where the tumor was. You can see how much it has shifted away from the fovea. Its peripheral edge is the same. You can compare it with the initial manifestation. Its peripheral edge is the same, but it is posterior edge has moved away from fovea macula. So it's a great advantage in terms of salvaging vision. The next one is about SRF. SRF itself goes away very quickly. This is one more example where even the fovea was not seen at all. There was no overhang. It was actually involved. Now, after the tumor has regressed, after 6 cycles, you can see a nice foveal reflex. So even tumors which are involving the fovea can leave the fovea and give you a good or reasonable amount of vision when you use intravenous chemotherapy. And of course, SRF also goes away. That adds to the advantage. So intravenous chemotherapy shrinks the tumor, resulting in a much smaller scar. Tumor regresses towards its source of vascularity, thus maximizing exposure of the macula and fovea, and exudative retinal detachment settles down. It was the standard of care in early 2000s, but now it still is standard of care in developing countries or middle income countries such as India, where we use it only because many of our families can't afford intra-arterial chemotherapy, which has now become the standard of care. It has reasonable success, there's no doubt at all. And unfortunately, in a situation where majority of patients present with group D or group E retinoblastoma like India, intravenous chemotherapy does have some limitations in terms of success, but it is still used. In situations where the tumor is much larger and vitreous are much extensive, we do have a choice of delivering high-dose intravenous chemotherapy. There's little more of systemic complications such as bone marrow, toxicity, etc., chance of infection, but it is very useful where that is the only option that is available. These are some of the examples of high-dose intravenous chemotherapy, which we still use. It's about 5% more effective than standard dose IVC in group D and E retinoblastoma, specifically in group E retinoblastoma when we combine it with periocular chemotherapy. Now, intra-arterial chemotherapy has now become an established technique. Only problem is that it does not take care of systemic micrometastasis. So if you have a group E retinoblastoma with high risk factors, it may not be a good idea to use intra-arterial chemotherapy. I don't have any solid evidence to say that, but it is a presumption that if the child has microscopic metastasis already or called micrometastasis, then intra-arterial chemotherapy will not reach systemic circulation in enough concentrations to take care of it. So theoretically, there's a risk of higher metastasis if you use it. The second is that it is expensive. Being expensive, many of the families can't afford it. The process itself is very simple, but you'll need the help of an interventional neuroradiologist or an appropriate specialist to get you into the ophthalmic artery. Once they get you into the ophthalmic artery, you take over and inject 1 to 3 drugs. Now, the drug of choice is melphalan. All over the world, melphalan is the drug of choice. If you use a single drug, that is melphalan in the dose that is shown, which is age dependent. If you have melphalan available, then you can definitely use melphalan. In addition to melphalan, you can use topotecan and carboplatin. The advantage of using topotecan and carboplatin along with melphalan is that you need a fewer number of cycles, so the expense is much less. If you use a single drug or reduced dose, then you'll need more number of cycles. If you use 3 drugs, then you will need less number of cycles. Response is very dramatic. You can see total bullous retinal detachment settle down and the tumor calcified with intra-arterial chemotherapy. Similar result here, similar result here. Even in recurrences on top of a calcified scar, the result is very impressive. So if you ask what is the best form of treatment for group D and D retinoblastoma, definitely intra-arterial chemotherapy. But what about group B or C? Group B or C will have 100% eye salvage irrespective of which form of chemotherapy you use. Intra-arterial chemotherapy does have 100% eye salvage. Group C intra-arterial chemotherapy does have 100% eye salvage, and so does intravenous chemotherapy. So there is no change in prognosis in group B and C. In group D, it makes a huge difference. In group D retinoblastoma, intravenous chemotherapy may give you about 80, if you stretch it a bit, 85% eye salvage. Whereas if you use intra-arterial chemotherapy, your eye salvage jumps by about 5 to 10% to about 90%. In group E, again, it falls down. In group E, there is some advantage, maybe about 5% advantage in using intra-arterial chemotherapy. Intravenous chemotherapy gives you about 45-50%, whereas with intra-arterial, you get about 50 to 55% eye salvage. But the only issue with intra-arterial chemotherapy in group E is that if there are clinical risk factors which which actually harbinger histopathological risk factors, then using intra-arterial chemotherapy itself may have a theoretically high risk of developing systemic metastasis because the drug doesn't reach systemic circulation in enough concentration. That's about it. Otherwise, it's fine. The only disadvantage of using intravenous chemotherapy is that the child will have systemic issues. And if you want to avoid that, then intra-arterial chemotherapy is the way to go. Now, that doesn't mean that intra-arterial chemotherapy can be used only in isolation. Many of these children, after completion of intra-arterial chemotherapy, may need an extended course of intravenous chemotherapy as well because of unregressed tumor, residual tumor, or recurrent tumor. Secondary IAC has excellent success. So if you have a situation where intravenous chemotherapy has been given and the child has a partial regression or the child has recurred, then if you use intra-arterial chemotherapy as a secondary measure, then you have very good success. What about the technique itself? Technique itself is very much perfected in India. In the last 100 consecutive cannulations, 98% had positive cannulation rate. Only 2 had to be ballooned. This was an old data, but now I'm sure this is improved to closer to 100%. So cost is only the barrier. There is no other barrier to using intra-arterial chemotherapy, just the cost. If we can bring it down, then we'll be much better. So IAC does make a difference for group D and E retinoblastoma and for larger recurrences. Now about the vitreous seeds. How do vitreous seeds form? Vitreous seeds can form in many ways. One is that there's a break in the internal limiting membrane and growth of vitreous seeds. That's one mechanism. There's a breach of ILM and growth of vitreous seeds. Second is in an endophytic tumor, there could be sprouting of vitreous seeds from the surface of the tumor. It's nothing but an advanced manifestation of an endophytic retinoblastoma. Now, once the vitreous seeds form, there are 2 mechanisms. One is adherence independent growth. That means that the tumor cells don't need a substrate to grow. They can proliferate in the vitreous as free floating spheres, just getting nutrition from the vitreous. That's called adherence independent growth. The second mechanism is adherence dependent growth. That means that they need a retinal substrate. They settle down on the retina. There are some plants which, I have seen a plant where the tips of the leaves will have these plantlings or seedlings and they drop onto the soil and they start growing. It's something like that. So these seeds will need have a retinal substrate to start growing. So they form epiretinal seeds. So epiretinal seeds are a category of vitreous seeds which have only settled on the surface of the retina. They are on the retinal surface. So that's how they are different, right? They could be in any location. So now based on OCT, we just don't have classic vitreous seeds. Vitreous seeds are in the core of the vitreous. We have prehyaloid seeds, we have subhyaloid seeds, we have epiretinal seeds. Up to epiretinal seeds, the mechanism is the same. That means that they sprout out from the surface of an endophytic tumor and either proliferate in the vitreous or settle on the anterior surface of the retina and start proliferating. When we talk about intraretinal and subretinal seeds, then the mechanism is totally different. These are not endophytic tumors. These are exophytic tumors or diffuse infiltrative tumors which grow in the layers of the retina. That is how intraretinal and subretinal seeds form, right? So although they're all vitreous seeds, they're all different. Now, intracameral seeds, there are 2 types again. Depository, which are just the vitreous seeds which come through the zonules and get deposited in the anterior chamber. That is perfectly all right because they are a form of vitreous seeds in the anterior chamber. Infiltrative is much serious because that means that the ciliary body is infiltrated. Consequently, the anterior chamber angle and the iris are infiltrated by the tumor, and then the seeds get into the anterior chamber. How do you diagnose it clinically? If the pupil is nice, round, and central, then unlikely to be infiltrative. If the pupil has a squarish edge, a D-shaped pupil in the segment where this seed is located, that means that there is possibly iris and ciliary body infiltration. Look at the pupillary architecture or NVI to clinically diagnose these seeds. Now, classic vitreous seeds, I already mentioned. This is just the OCT. I'll skip these slides for the lack of time. Epiretinal, intraretinal, and subretinal. There's a combination of seeds here. Depository anterior chamber seeds which have walked through the zonules and come into the anterior chamber. Infiltrative anterior chamber seeds, you can note that the pupil is squarish here, confirming clinically that it is infiltrative anterior chamber seeds. Now, morphological classification depends on how the seeds look: dust, cloud, and sphere. depending on the regression pattern also varies. Does disappear, DD, does actually disappear with appropriate treatment. Cloud also disappear. Cloud clears, does disappear, clouds clear, and the sphere becomes smaller and crenated. These spheres have a way of regression. They can become smaller in size and much denser. That is one way of regression. Second is that the sphere may have an eggshell calcification around them. That is a second way of regression. Third is that the spheres may become crenated like that and may become pigmented. That's the third way of regression of a sphere. Sphere may also become completely calcified and much smaller and look like a larger dust particle. So there are many ways of vitreous seed regression. That's a mixed configuration of vitreous seeds. Now, how do we treat vitreous seeds? If a tumor is viable in the retina and there are a lot of vitreous seeds, you cannot get into the vitreous. So you still treat them with intravenous chemotherapy and intra-arterial chemotherapy and add on periocular chemotherapy for an additional measure so that intravitreal concentration of chemotherapy is slightly larger. But if you have the retinal tumor already conquered and what is left are viable vitreous seeds, then the gold standard for treatment is intravitreal chemotherapy. And whenever you do periocular chemotherapy, this is always deep posterior subtenons in oblique meridia between the recti. Spare inferior oblique if possible, avoid that particular quadrant and give everywhere else, and rotate the quadrant. Carboplatin causes a lot of fibrosis. Topotecan is the drug of choice. And it actually works well. You can see these situations where vitreous seeds have regressed following chemotherapy and periocular chemotherapy. This is the first case where I give in periocular carboplatin. Other eye had already been enucleated. We did not have intravitreal chemotherapy at that time. So the child received high-dose chemotherapy for the retinal tumor and periocular carboplatin for the vitreous seeds. You can see nice regression. It works well actually, but not 100%. This is the report that we had published earlier about 75% eye salvage carboplatin with high-dose chemotherapy. The recent publication of ours is with periocular topotecan, but not high-dose chemotherapy. So periocular topotecan also works, but with standard dose chemotherapy, whereas carboplatin, this earlier study that was published in ophthalmology, was with high-dose chemotherapy. So it's not bad to give periocular chemotherapy when you can't get into the vitreous. But the moment the retinal tumor has regressed, you have intravitreal chemotherapy coming in a big way. Now, these are the criteria. Retinal tumor should not be large, residual, or active. Choose a safe site. That means that there should be no vitreous seed or a tumor in the area where you're going to give the injection. Always exit through eyes. So if you are doing intravitreal chemotherapy, you always choose a site which is safe. Put in the needle with a smallest gauge needle, 30 gauge needle is preferable. Apply cryo around it and exit through eyes. That actually takes care of any of the seeds or the cells that may come out through the puncture site. Then on top of that, you do injection site chemotherapy. Once you remove the needle, you cryo thrice over the injection site, again for microscopic cells that may come out. And if you have any fear that the cells may actually come out, then you do what is called the death by water technique. Any water, including say distilled water, can kill tumor cells which have inadvertently come out. There's a form that is described, but we don't use it very often. You can also raise a bleb of subconjunctival topotecan. So if somebody asks you what are the safety enhancement measures, then these are the safety enhancement measures that you use for intravitreal chemotherapy. Now, what are the drugs that you use? The drug that is used in the West is melphalan. Melphalan was the drug of choice, is still the drug of choice in the West because it's very effective and takes care of the vitreous seeds. But they used to use a weekly protocol, which makes it logistically difficult to get the child every week into the OT and give these injections. Weekly protocol of melphalan is currently not used by us, at least because we have discovered that melphalan, apart from its logistic hazards, also causes major complications in pigmented eyes such as ours. RP changes is one major complication that we have with suboptimal vision as a consequence. Apart from that, uveitis, cataract, retinal toxicity are all complications. So we have shifted over totally to intravitreal topotecan, which is very safe, no retinal toxicity, needs a lazy 3-weekly or 4-weekly injections, and is very effective. 30 microgram, 3-weekly or 4-weekly is what we use. It takes about 2 to 6 injections for the seeds to go away, and there is no retinal toxicity so far. All these patients have been treated with intravitreal topotecan and they've all done well. Irrespective of the extent of the seeds, they all do fairly well. Suppose a child is refractory to topotecan alone. This is how we began this larger tumor and a bunch of vitreous seeds. After intravenous chemotherapy, tumor is gone, but the bunch of vitreous seeds is still absolutely the same and it is right over the macula. After 6 injections of topotecan, they're much less, but they're still there. And when we added low-dose melphalan, they're gone. But note that there is retinal pigment epithelial change. So melphalan is good even in low dose. Even if you use it as 10 microgram, it can still cause RP changes. So it's reserved to the end. Whenever you use combination therapy, we use low-dose melphalan. Now there is a system of increasing the dose of topotecan to up to 45, 50 microgram without any complications. So we use standard dose first. If it doesn't respond, we hike the dose of topotecan or reduce the frequency. Then finally, if it is still residual, we use low-dose melphalan. Initially, when we published this in BGO, we had published very promising 100% result because we had very selective cases here. We had very carefully selected out these 17 patients for a new form of treatment. But now we have kind of generalized this treatment. We use it in everybody without any pre-selection. So success is not as high as 100%. It's dropped down to about 85, respectable 85, 90%, which is still good without any complications. Now, what are the regression patterns of vitreous seeds? Complete disappearance is called type 0. When vitreous seeds convert to calcified seeds, it's called type 1A, or crystalline refringent dust. That means refractile particles within the vitreous cavity, but no discernible seed. Seed is when you can see them separately. That's a seed, calcified seed. When you have this kind of a configuration where there's a bunch of refractile things where one cannot be isolated from the other, that's called a crystalline refringent dust. That's Monier's terminology. Amorphous non-spherical seeds are like, they're in the amorphous is like amoeba, various forms of indescribable forms of seeds which are non-spherical. They're obviously not conforming to the sphere. That's type 2. Combination of 1 and 2 is type 3. The extended indications for intravitreal chemotherapy are the depository or infiltrative seeds, where you have a choice of giving intravenous intravitreal chemotherapy, like topotecan, like this child received intravitreal chemotherapy and the anterior chamber seeds also went away, or you can give intracameral chemotherapy 5 microgram and they do very well. This is a child where 5 microgram of topotecan was given into the anterior chamber and the child did well. Suppose the child has diffuse subretinal seeds or intraretinal seeds, intravitreal chemotherapy can still work. So you don't have to do TTD and cause so much of scarring. You can still give intravitreal chemotherapy and reduce these seeds in extent and give localized TTD. So RB seeds seem to have been finally conquered. Now, I don't have time for rest of it. Volika?
You have time, sir.
Okay. So now enucleation, the trend is changing from 95% to 25% in 2005. Now I think it's less than 10%. That's my fair estimate, but it's still the primary enucleation. But it's still the treatment of choice in advanced unilateral retinoblastoma, where there is neovascular glaucoma, etc., where the families don't want to go into a complex treatment protocol. We don't want to be kind of coming back every month worried about the regression of the tumor. They want to get rid of the tumor once and for all. In a non-seeing eye, it is the treatment of choice. So any eye with neovascular glaucoma or neovascularization of the iris, anterior segment infiltration, ciliary body infiltration, hyphema, vitreous hemorrhage, ophthalmos, sterile inflammation, these are all the indications for enucleation. These are all called clinical risk factors. Now, does neoadjuvant chemotherapy before enucleation, is there any role? There is absolutely no evidence that neoadjuvant chemotherapy before enucleation actually changes prognosis. But if at all you use it in situations where safe enucleation is not possible, such as a child with ophthalmos or staphyloma or with severe steroid inflammation, or if the parents are not convinced about primary enucleation and they want to take time to mount the eye before you finally have them agree to enucleate, then you can start neoadjuvant chemotherapy. But whenever you start it, you have to complete 6 cycles as per protocol. You cannot start neoadjuvant chemotherapy, stop it at 2 cycles, then do enucleation and do nothing about it. Because neoadjuvant chemotherapy would have downstaged the disease. So when you do histopathology on an eye that has undergone neoadjuvant chemotherapy, your histopathological risk factors will all be missing, and you'll be under the false sense of security that the child never had choroidal invasion or never had optic nerve invasion. Then you are incomplete in treatment. So whenever you start neoadjuvant chemotherapy, you are supposed to complete 6 cycles. Even if you bring in enucleation after the 2nd cycle, you still have 4 more cycles to give after enucleation. That's very, very important. Now, eyes like this cannot be safely enucleated because there is periocular inflammation, scleral infiltration. If you attempt to enucleate this eye, you will be a mess because there'll be a lot of bleeding intraoperatively. Sclera is all mushy and you may perforate it, you may let the tumor out of the eye, and you may even get a small optic nerve stump. So never try to enucleate an inflamed eye. Give chemotherapy, let it go into atrophy bulbi, then you do a safe enucleation. Enucleation technique has become refined, but what we should always aim to achieve is the longest possible optic nerve stump. Anything less than 15 millimeter is suboptimal. Example is this child, if you were to go by the textbook and take 10 millimeter, you can see optic nerve is involved here. You would still be left with tumor at the resection margin. If you extend the length and go to 18, 19 millimeter, you have a much better chance of getting resection edge negativity. Of course, you can do MRI now to see how much is the length of the optic nerve that is involved. But if MRI is never 100% sensitive or specific for optic nerve, unfortunately, despite the best MRI specialist reading it for you, you may still have optic nerve sheath involvement, which may go missing on MRI images, or very minimal skip lesions on the sheath of the optic nerve, which are totally undetectable on MRI, and the cut end may still be involved on histopathology. So MRI is good, but it is not 100% reliable. So safe enucleation would mean the longest possible optic nerve stump. Second is that you have to promise cosmesis and deliver it to the parents. This child has undergone primary enucleation. Just check with Sunil if he's okay if we continue it for some more time.
He messaged already, sir. He's absolutely fine.
Absolutely okay, fine, sir.
All right. So this is taking a little more than I thought. Anyway, so primary enucleation whenever you do, or secondary enucleation whenever you do, implant is mandatory. Primary implant is mandatory so that you can give the cosmesis that you have promised to the parents. If you have this kind of a cosmesis delivered to a child, then many parents would agree for primary enucleation or even secondary enucleation because they finally expect cosmesis when they want to sacrifice the eye. So what technique that we use is called myoconjunctival technique. I'll just show you a quick video of myoconjunctival technique. You always begin with a small lateral canthotomy and peritomy as close to the limbus as possible. That's the peritomy being done using a blunt tipped conjunctival scissors. So you should not use a sharp tip scissor so that you don't accidentally perforate the eye. Once you do peritomy, you dissect tenons, anterior and mid tenons in oblique meridia between the recti, then tag the recti with a 4-0 silk suture at the insertion, and use one more tag suture which is 6-0 vicryl about 8 millimeter distally. Then you disinsert the muzzle with a nice stump on either side so that your sutures don't slip out. Each recti is treated similarly. Like you start with medial rectus, then go to inferior, lateral and superior, and finally superior oblique and inferior oblique. All these muscles are transected. Obliques are never tagged. Small relaxing incision in the conjunctiva, let the eyeball prolapse through the blades of the speculum, identify the lateral rectus, insert a 15-degree curved tenotomy scissor between the eyeball and the lateral rectus and go hit the bone at the orbital apex. Lift the scissor by a couple of millimeters so that you don't cut structures that pass through the superior orbital fissure. Cut only the optic nerve and deliver the eye. As you deliver the eye, look at the extraocular extension. You can see the optic nerve length is 20 millimeter. That's very liberal, and you can put an implant posterior to posterior tenons. Suture the posterior tenons very carefully because that is the best barrier for the implant. We always use silicone or PMMA implant, not an integrable implant, because integrable implant don't stand radiation. If at all you have to give it. Myoconjunctival technique would mean that you place the muscle sutures just short of the respective fornices. This increases implant mobility dramatically, and the child will have a much better cosmosis. And finally, you close the anterior tenons by taking juicy bites of anterior tenons using 60 vicryl. Very closely placed sutures so that anterior tenons is the second barrier, and conjunctiva is closed using a continuous key pattern suture, which approximates the conjunctiva and keeps the edge together while not burying the conjunctival epithelium to avoid cyst formation. Conformer is mandatory, and after that you place a suture tassel so that the child doesn't finger out the conformer and worry his parents. Now, these are the steps that you would take for a long optic nerve stem and a safe enucleation. Now, inspection of the eye following enucleation is very important. Length of the optic nerve, and also optic nerve should be flaccid like this. When you hold the eye and let the optic nerve drop, if it is straight, ignore the forceps. I just supported it with a forceps just to show how a rigid optic nerve would look like. It will not fall. A optic nerve that doesn't fall flex like this means that there is optic nerve extension clinically, 100% sure. If an optic nerve falls flaccid like this, clinically at least, there is minimal chance of optic nerve invasion. Next thing that you inspect is hold the optic nerve sheath and make sure that it is separable from the optic nerve. So it is pinchable from the optic nerve. All these maneuvers have to be done very gently. And all areas where the sclera is thin, thick, pink, or indurated, or if there is an abnormal vessel in the sclera, all these have to be marked. Why should these be marked? Otherwise, the pathologist will take a pupillo-optic section, and at most, if he's very, very good to you, he will take lateral callets, but it may still miss areas where there may be possible extraocular extension. So it is our duty to warn the pathologist that these are the areas where there are potential histopathological risk factors, and mark out these areas for the pathologist to take section through those areas. Otherwise, they will be missing histopathological risk factors, which are these. If you miss histopathological risk factors, which about 50% of Indian eyes are supposed to have, then there's a high chance of metastasis. Anterior segment invasion, infiltrative, ciliary body invasion, choroidal invasion more than 3 mm in diameter or 3 mm in thickness, which is called major choroidal invasion, or optic nerve invasion beyond the lamina cribrosa, or a minor choroidal invasion with optic nerve invasion of any extent are considered histopathological risk factors, in the presence of which every child should get adjuvant chemotherapy. If there is optic nerve edge transection, positivity, scleral or extraocular extension, then there should be adjuvant EBRT to be given. Does adjuvant therapy really help? There were many studies before we did our study, which was in exactly 20 years ago. This was post-enucleation adjuvant therapy in high-risk retinoblastoma, where we found that if a child had high-risk factors and did not receive adjuvant therapy, then the chance of metastasis was as high as 24%. If you identified the histopathological risk factors and gave adjuvant therapy, then the chance of metastasis can come down to 4%, which will give you a clear 20% survival benefit in these children, which is very, very significant. From 65% life salvage, your center will jump to 85% life salvage if you were just to identify high risk factors and deliver adjuvant chemotherapy. Fortunately, this particular finding of ours from one center was validated by an international multicentric studies spearheaded by the Children's Oncology Group. This showed exactly the same data. Now this has become a reliable treatment modality in all children with histopathological risk factors. So enucleation is definitely not the end of clinical management of retinoblastoma. It is just the beginning. Now, last bit is about orbital retinoblastoma. Incidence varies from country to country, and it falls here. Stage 3A is where orbital retinoblastoma would fall, and in TNM, it falls into stage CT4. Right? So orbital retinoblastoma has poorer prognosis. 70% mortality is what we had with primary, where child presents with orbital retinoblastoma. This is how the child may present clinically or radiologically, some of which can be detected on an MRI scan. Secondary is when you have already done enucleation, then there is an orbital recurrence. Accidental is when you do this hyphema drainage or vitrectomy in a child who has retinoblastoma, where you're not aware that the child has retinoblastoma, and that's accidental. Overt is when radiology misses it and you find it on the table when you enucleate it, there is a nodule which MRI has missed. Microscopic is when everything misses it, and the pathologist tells you that there is residual retinoblastoma. That means scleral full thickness involvement, extraocular extension, or optic nerve involvement to the transection. 70% mortality is where we began, and with the protocol that we initiated with Anna Meadows as the one who kind of encouraged us to use this form of therapy, which is called multimodal treatment, where we began with high-dose chemotherapy, perform surgery after radiological documentation of resolution of orbital retinoblastoma, then deliver stereotactic EBRT, and continue chemotherapy for up to 12 cycles. So this is how the child presents. This is how the child looks after neoadjuvant chemotherapy. Showing you one more example, this is the orbital retinoblastoma. Eye has gone into a comfortable phthisis. You can see change after 3 cycles. Orbital component has reduced. Then you do a enucleation with a long optic nerve stump, give stereotactic radiation for the microscopic residual, which obviously be there, then give adjuvant chemotherapy. So that's a 1 year long treatment. Does it work for optic nerve extension? It does work. You can see optic nerve caliber being so thick, completely normalized after neoadjuvant chemotherapy, now ready for enucleation. Does it work for limited intracranial extension? It does work. You can see cavernous sinus being involved here, completely gone after neoadjuvant chemotherapy. All that is left is at the superior orbital fissure, which can easily be radiated. Cosmesis is a big bonus here. All these children don't have to suffer orbital exenteration and the cosmetic abnormality that it produces. They can still use a custom ocular prosthesis. Does it work when the eyelid is involved? It does. You can see eyelid becoming totally normal. We have done nothing to the eyelid, but we have treated the tumor nevertheless. That's the implant in position and cosmetically gratifying. So orbital RB also now has a cure. With all this put together, in India currently we have about 95% life salvage, which is much better than we began with. Small measures, small steps, but cumulatively it all adds to improved prognosis. Identification of HR itself can add 20% life salvage. Chemotherapy can add 10% more. With all this put together, we have much better chance. Overall, about a third of patients still need primary enucleation. That was slightly kind of a data that was gathered over 2 decades. So currently, if you ask me, only about 10% may need primary enucleation. Chemoreduction has 90% eye salvage, where the eye is saved, 95% have some vision, and where vision is measurable in older children, 50% fortunately had vision of more than 20/40. That doesn't mean anything except that the tumor is not in a visually crucial area. That's all it means. Or we have been successfully able to uncover the visually crucial area by initiation of chemotherapy or appropriate treatment measures. Do these children do well? They do extremely well. This child has bilateral retinoblastoma. Can you expect him to draw so beautifully? Well, there are children who have drawn portraits. They have very little vision, but I don't know how do they get that vision work for them. They work very beautifully and they're absolutely fine. They do very well at school. Once they survive, I think they simply sprout. This is a child, who's into music. What kind of vision do you expect in this child? A macular scar, but look at how talented she is, right? So they do very well. And this child is... Sound is audible?
Yes, sir.
Yeah, just look at the kind of tumors that she has unilateral, absolutely no vision in this eye, and she has good vision in the other eye, but she's able to absolutely work like a normal child, even better. There are socioeconomic barriers to the challenges as well. Of course, we use governmental support and of course NGOs to channelize support for these families, travel concession, social insurance, etc. And also we chase all the families and get back these children well in time before they advance further. If they have abandoned treatment, give them all kinds of inducements and threat to get them back into treatment. Future prospects, of course, lie in genetics, early diagnosis, improved focal therapy, focal drug delivery, and advocacy. This is a slide borrowed from Dr. Galli. Father had bilateral retinoblastoma. They had the first child with bilateral retinoblastoma. When they were into the second child, they had a prenatal delivery. First child was born with retinoblastoma, so the second child had an early induced delivery. So as Dr. Gali watched, tumor was born and she lasered the tumor. At that time, laser was the treatment available. Child survived with 6 vision. So there is early delivery that can be induced in a family where children are born with retinoblastoma. There's also non-invasive pre-implantation genetic testing that is possible to eliminate retinoblastoma from the families. There are tools of advocacy.
When he's sad, frightened, or when he's asleep. You can tell many things from a child's eyes, including if he's got cancer.
This is a South American television campaign which increased the uptake of early diagnosis of retinoblastoma many folds. Similarly, we have apps now. If you have a child at risk, then parents can use these apps to sort out pseudoleukocoria from leukocoria. They can also send pictures over internet to you for further evaluation. These can be used also by healthcare workers to take a picture of the child's eye and transfer it to further higher in medical screening circles, like such as ophthalmologists or pediatric ophthalmologists or retina specialists or ocular oncologists for sorting out these as normal. So I've taken you to the depth of retinoblastoma. Let me bring you back to the surface just to tell you trends in life salvage currently have been driven by neoadjuvant chemotherapy, identification of risk factors, and multimodal treatment. Much more, 98% life salvage is what we can expect. Trends in eye salvage have been driven by intra-arterial chemotherapy, intravitreal chemotherapy, and brachytherapy. And currently, we have about 80 to 90% eye salvage. And vision salvage has been driven by intra-arterial, intravitreal chemotherapy, especially topotecan, and ICG enhanced TTT, and it's up to 80 to 90%. In conclusion, I would say that early diagnosis is the key to success. General awareness and screening of high-risk patients is very important. We have app-based screening. We have to identify masquerades, both retinoblastoma masquerading as something else and something else masquerading as retinoblastoma, so that we can avoid unnecessary enucleation. Management does seem complex, but it is a very straightforward, individualized management approach using a team which comprises of everybody, including a pediatric oncologist, a chemotherapy nurse, a pathologist, a geneticist, and of course, an ophthalmologist and an oncologist. Current trend is towards chemotherapy and focal therapy with improving life, eye, and vision salvage. Intra-arterial and intravitreal chemotherapy have brought about a paradigm change in eye salvage in recent times. Neoadjuvant adjuvant chemotherapy have definitely reduced the rate of enucleation and also post-enucleation metastasis. And all these treatment modalities, let me confirm, are cost effective. They cost less than the cost of a multifocal intraocular lens for a child for the entire treatment. And this is the video that I would end with. This child has undergone bilateral enucleation, but he has very high spirit and is doing extremely well, learning Braille, etc. This is one of my fellows who is singing with him. So it takes a village to treat a child with retinoblastoma, it's said, and everybody gets involved in the management of retinoblastoma, and there is a lot of hope. It's work in progress. The story has never ended. It's just reached its midway, and we definitely sure in my lifetime at least that we'll achieve much better success with retinoblastoma. Thank you, sir. Thank you so much.
Thank you so much, sir. Thank you so much for the wonderful talk, and from the parents' side, from the kids' side, and from the fellows' side, who are spread all over because of you. We thank you for putting it out there, putting all the treatment modalities out there. And even though you wouldn't like this, but here is something from one of your patients as a surprise to you. So this is a picture that has been drawn by one of your patients who is one-eyed and has 6/60 vision, and he actually has his entire Facebook, Instagram page where he draws and he sharpens his skills each and every day, and his drawings are only getting better. So this is something sent by him for you. I hope you don't kill me for putting it up there. But thank you so much, sir. Thank you so much. We have few questions. I would just square it down to one or two questions, sir, that have been on YouTube. One is Dr. Ramesh, who has asked that, is there any evidence or any regimen which combines systemic with intra-arterial chemotherapy?
Not
And
at
what
the
will be the
same time.
advantage?
Not at the same time. You can use intra-arterial chemotherapy, intravenous chemotherapy in a combination, but not together. As a protocol, you can begin with intravenous chemotherapy, and if there is suboptimal response, you can shift to intra-arterial chemotherapy. Similarly, you can begin with intra-arterial chemotherapy, reduce the bulk of the tumor, and whatever that is residual, you can use intravenous chemotherapy. Sometimes during the course of intra-arterial chemotherapy, there is narrowing of the ophthalmic artery caliber, or if there is any logistic hassle in getting into the ophthalmic artery, etc., cannulation being difficult, then we don't risk intra-arterial chemotherapy any further. We shift to intravenous chemotherapy. So they can be used either which.
Right. So another question is from Dr. Osama Abdullah. He is from Sudan, and he has asked him that in his country, a lot of patients present very late, and you have explained in your slides as well, but they would like to know how to manage these late cases and what would be the advice, and how to establish a specialized center for retinoblastoma in Sudan. So this is the last question for you, sir.
Yeah, specialized center, when you want to establish, you have to get the entire village trained or the team trained. You have to have an ophthalmologist with special interest in ocular oncology, maybe an oculoplasty specialist already, or somebody who's a retina specialist, or an ophthalmologist who does a fellowship in ocular oncology and oculoplasty. That is the starting point. And then that person has to put together a team of a pediatric oncologist and a pediatric chemotherapy nurse. Ideally, chemotherapy for retinoblastoma is done in ophthalmology center so that they don't get lost in the big bad world of oncology. Otherwise, parents get very disheartened and feel lost in oncology hospital. If we have chemotherapy in an ophthalmic setup, that's even better. Then a good pathologist who is willing to learn and also try to get you those histopathological risk factors which you're looking for, so that you can take additional measures. Genetics is a last add-on. If you can add it on, that's great. So you have to get the entire team trained, but the starting point or the nucleus of everything is not an oncologist, it's an ophthalmologist. Advanced RB, there are a lot of protocols, and it depends on what stage and group it is. We can always devise the treatment protocol appropriate for the child.
Right, so thank you so much, sir, for covering it so very beautifully. We all were glued to our screens, and we will have...
Does she have anything to say?
She's
special guest.
Actually traveling, so I mean, like, she's listening to your talk while she's traveling. Okay. So yes, sir. And so the next
talk sir, I'm there. That was a wonderful talk.
Where are you?
I just reached home. Give me a second.
Okay, that's all. That's all right. Be comfortable. That's fine. That's fine.
Yes, sir.
Right.
All right. Good night then. Thank you.
So the next talk will be on the 20th of April, and that will be on uveal melanoma by Dr.
Thursday. That's on Thursday, not
20th April, right, sir?
Yeah.
20, right, sir? Right. And that will be by Dr. Feroz P. Manjan Davida, ma'am. So we'll see you all there. And Mritika has joined too.
Thank you.
Thank you so much.